Hi, everyone, and welcome to today's presentation. My name is Chloe Setzos, and I'm the project coordinator here at Capital Link, and I'd like to thank you all for joining us today. Today's webinar, titled Focus on Behavioral Health, Preparing Internal Systems for Gathering Costs Data, is the second webinar in a four-part webinar series offered through the Delta Center for a Thriving Safety Net. The full entitled Understanding Your Costs in an Evolving Payment Environment has been developed by Capital Link with input from JSI, and we'd like to thank JSI, the Robert Wood Johnson Foundation, and the Delta Center for supporting this effort. You can access recording and PowerPoints from the prior webinars in this series on the websites of Capital Link and the Delta Center. Today's webinar will also be recorded and posted on websites as well. Today's presentation will last about 50 minutes with 10 minutes for questions at the end, but feel free to ask questions through the presentation in the chat box located on the GoToWebinar toolbar on the right-hand side. You also can have a PDF copy of today's slides available through the handout section of your GoToWebinar toolbar, as well as on our website after the presentation concludes. Fiber, project consultant at Capital Link, and Bob Urquhart, consultant and retired FQHC CFO, will be our speakers for today. With that said, I'd like to turn it over for Dave to get started.
Thanks, Chloe. And greetings, everyone. Thanks for joining us again today. You can move the slide on, Chloe, and we can get this started. This is as Chloe mentioned, first of all, I'd like to echo her statement about our appreciation for the support we've gotten from the Delta Center and JSI and Robert Wood Johnson Foundation. This is, I mean, obviously we're probably wrong people to ask, but we think this is incredibly important work, largely because of the transitions going on in the world of healthcare and the way you get reimbursed. And so this four-part series that we have put together, initially for primary care providers and now for the behavioral health industry, is focused on helping you understand how to go about categorizing and allocating your costs so that you can be a knowledgeable participant in the reimbursement discussions you're going to be having with your payers, and you have had. And that's going to be the focus of these sessions going forward. Today's session is largely about the nuts and bolts of how you go about categorizing these costs. And you'll be hearing mostly from my colleague, Bob Urquhart, who's a retired CFO at a health center. And so we've seen, he's seen a lot of this and done a lot of this, and his background is tremendously valuable. If you didn't see our first session, you can get it on the web. It was called Cost Allocation. Basically a quick run through about formulas, how to break down costs for cost per visit and cost per client, just the 30,000-foot level calculation, if you would. Next slide, Chloe. This one is, as we mentioned, is going to be a lot more detailed. So please don't hesitate to use your chat button or to put in questions. And also at any time, if you write them in, we will get back to you individually. If we don't get to them on the session itself, verbally here while we're speaking, we will respond to everybody individually. So if you have a point you might think might be some minutia or particularly meaningful to you, it's fine. Send it in. We'll get back to you on a one-on-one basis if need be. Okay, so I'm going to I'm going to transfer now to Bob because he's going to be doing a lot of this discussion going forward. Do you want to flip slides, please?
Okay. Again, welcome everybody, and thank you for joining us again. So as David said, my role in the past has been as a chief financial officer in a health center environment and also in other industries. And so that gives me kind of a unique perspective in the whole topic of capturing costs and recording costs and the system and support that you need. And what you find is that a lot of that stuff is universal. I mean, it's not quite one size fits all, but it's pretty close. There's a lot of commonalities across industry that can carry over. And actually, in some of the stuff from the retail world and from other parts of the business world can actually be helpful to the healthcare industry. We've learned some things from that to help us do a better job in measuring costs and managing costs. So as we start this today, I mean, there are things that we need to consider for capturing costs. First of all, you need to consider what are your system's capabilities. Now, your general ledger system your EHR and practice management system, your payroll systems. What do you have, and what are they capable of? How big are they? For example, I worked for the health center that was running the general ledger on a $9.95 a month QuickBooks thing. So therefore, we had a lot of problems trying to capture costs. We had to get off of that, and we actually bought a real system. So you got to look at what your system has and what are they capable of doing. The other issue for a lot of this is staffing. In the healthcare world, behavioral health and in healthcare, overall healthcare, staffing is always an issue. How many people do you have in the finance group or in your patient accounts group? Or how many people do you have in your support groups that you need to help capture the information and data to get it into the system? So staffing is kind of an issue that needs to be talked about too when you're trying to figure out how you're going to do all of this. Organizational commitment is a real big one, in the sense that you need to have a buy-in, starting with the CEO and working with the senior executives and all the way down through the management level, that everyone is in agreement that gathering costs, properly capturing costs, getting into the department or service line level so you can make good, solid judgments on how your center is running and how your program is running, has to be someone everyone buys into, because you're going to rely on them to provide the information to you and to take the information you give them and make organizational and operational decisions. So you need to make sure that you spend a lot of time getting the organizational commitment and getting the people behind this whole effort. And then something that sounds pretty simple, but it's defining your objectives. What are you trying to do? We say measure cost, capture cost. You can do it at a very high level and just say, I'm just going to capture costs for the whole organization, and that's how I'm going to report it. You can go down to the very finite level and capture it, down to individual provider levels and individual, transaction levels, or you can get it at the department level, at kind of a site level. What we're going to talk about today is mostly doing those things at a reasonable level, total organization, total department / service line, and be able to do that. So defining your objectives, what are you trying to achieve? What do you want to get out of this? So when you set up your systems and you do what the detailed work that needs to be done, you know where you're headed. What are you trying to accomplish? Right, next slide.
And I'm gonna add in there as we switch slides. Thanks, Chloe. I'm gonna add in just one more thing, and that Bob's a big basketball player, so we talk in sports metaphors all the time. But it's important to do this work so that you're not approaching your negotiations with your payers from a defensive point of view. You don't want to necessarily be a pure just recipient of rates. That may be where you are now, but if you look into the future, you have to be an active participant then. You got to kind of take some, get on the offensive, take the game to them. And part of that is being able to be armed with all the cost data that you have in order to be able to justify the rates that you need. And no one on this call is going to be shocked to learn that by and large across the country, behavioral health is under reimbursed. And so there's a common objective we all have to go and work with our payers to convince them that in fact, our work needs to be better compensated so that we can keep these organizations thriving.
Yeah, thank you. That's a good point. And that applies to payers. A lot of us rely on grants and grant funding. It also helps with them too, to be able to show them, here's our organization, here's what we do, and here's where our shortfalls are, and here's how you can help us. So yeah, that's probably the overarching objective of all of this. That's the major point, is keeping that information, to, as Dave said, go on the offensive, fast break financing, So,
there you go.
So the priorities, when we start talking about how do you do this, the priorities have to be your chart of accounts and your general ledger. That's the record, the main record of the operation, your organization. That's where all of the data has to come from. And the general ledger and chart of accounts drive your whole business, how you get your information. So I think you have to have an expanded chart of accounts. You have to make sure that it's a very detailed level. And I have some examples behind this that I'll show you. It's not good enough to just say, we have supplies expense. It's better to say we have supplies expense, but within that, there are 5 to 6 different types of supplies. There are, medical supplies or client supplies or office supplies. There are different things that mean different things. When you want to know where your supply money's going, you want to look at those and make sure that you know at the detail level what those are. There's many examples of that, but that's one of my favorites because it's easier to kind of explain. So you have to have a very detailed chart of accounts. You have to have separate cost centers for all sites, departments, and programs. Now, meaning that if you have multiple sites, and we have an example later on showing a behavioral health organization with multiple sites, you want to know what's going on at each site. So each site needs to have its own chart of accounts. And when you want to look at cost relative to that site, you also make sure you know any departments that are in that site or programs, so that when you look at a financial result, you can go in and say, where is that coming from? Let's say, for example, you're looking at a great surplus. Where is that surplus coming from? Is it coming from a certain part of your practice? Is it coming from something else? Or on the negative side, you're having a drain on your funding. Where is that coming from? And then when you look at the details behind that, what do you want? What's your plan to fix it? And if it's going real well, what's your plan to keep it going real well? So having the separate cost centers and separate departments and programs is critical. Ensuring that your accounts payable module, and I say module because it's usually part of your general ledger system, you got to make sure that that mirrors the general ledger, how you want the reporting to come out, because you have to put it in that way. So the person doing accounts payable has to be very familiar with the chart of accounts, be very familiar with how your organization is set up, to make sure that all of the costs that go through there get paid, go through that way and get paid and charged to that department. And that includes, payroll. Your payroll, it has to be the same way, set up the departments match, so that when all of these costs go into your general ledger, they're going the way you want to get them out. And then you also want to make sure that your general ledger is structured so that you can get the reports you want. Now, most general ledgers have standard reports, and they'll tell you, we'll give you these, this is what it comes with. And most of them come with a report writer. We can kind of freelance and write your own. I think the best use of it is to do a little bit of both. I mean, the standard reports are usually pretty good, but I think when you really want to analyze a particular program or a site, or really drill down on the cost for a particular function, being able to go in and have a report writer you can develop and write the reports for the analysis you need to do is very important. Next slide, Cody. Thank you. So I mentioned chart of accounts. The next couple of pages, just to give you an idea of this is a chart of accounts from a healthcare organization. And I won't go through all of it, but it's usually set up this way. The first section is the balance sheet accounts, cash, accounts receivable, grants receivable. And if you look at just the first couple lines, petty cash, 1020, 1021 is cash, 1060 sovereign operating account. The status is active. It's an active account, and the designation code is based as a cash account. And if you go down a little bit further, you'll see grant receivables, and you'll start to see some bulk school receivables. In the ARO is basically it's an accounts receivable account. So that's
Sovereign.
I'm sorry, go ahead.
Sovereign was the name of your bank, wasn't it, Bob?
Yes, it was. Yeah.
Yeah. Okay.
Yeah, exactly. So when you're looking at that, this is the accounts receivable. The next page, sorry, go ahead, next slide. So you start looking at accounts receivable. It says Boston Medical Center, Celtic Care Found. These are all payers. You might be familiar with a lot of them. But basically, this is one, again, when you say you have accounts receivable balances, who owes you money? So this is by payer. So you book everything this way. You book all the revenue this way. You book all the payments this way. So when you look at your balance sheet and you see accounts receivable, it's going to have one line on it, but you're going to be able to look at these individual accounts and say, what is Tufts owe you? What is Celtic Care owe you? And then that way, when you're looking at days and receivables, if you have an issue that they're too high or too low, or your payments are lagging, you're not getting paid until 90 days instead of what you're expected 60, you can go into this level of detail and see where you need to go chase, where you need to have your client accounts people chasing to improve that number. Next slide, Cody. And this, I just wanted to give you a snapshot of the expense side. So when you get into salaries and fringe, that's usually the beginning of the expense part of chart of accounts. And this can be pretty lengthy, but you can see the salaries are broken out by incentive pay, overtime pay, fringe benefits are broken up by the type of benefit. And that becomes important because salaries and fringe are usually around 80% of the total cost of most healthcare organizations and behavioral health organizations that we've seen, and maybe even higher in some cases. So the same thing applies when you're looking at your total personnel cost. and you're looking at it in a over or under budget situation, you want to be able to drill down to these levels and see where is that happening. And then what action you're going to take. If it's a situation where your health insurance, your employee health insurance is not where you want it to be, well, how are you going to change the program? If your salary is over budget, you want to know if it's base salary, overtime salary, or is it incentive pay? If it's incentive pay, that could be a good thing, because in this environment that we're looking at here, this example, incentive meant that clinicians and providers were actually exceeding benchmarks. So therefore they were getting extra incentive pay, which also meant there was extra revenue in the top section. So this is just kind of a brief sample of what the expense side would look like. Next slide, Chloe.
And just to go ahead and turn slides, Chloe, but just to mention that incentive thing, again, we will be talking a little bit more about that in future sessions, specifically about the fact that it could be a variety of different provider types and with different kind of incentive plans, but that is a key aspect of this value-based programming is it's going to be focused on outcomes, and if you want to achieve certain outcomes, then it can be incumbent on you to try to create systems that incent those your providers to create those outcomes, if you will. So we'll be talking more about that.
So as I said a few minutes ago, this is kind of a sample reporting curve. Basically, I'm using a counseling center, saying that the sites that are set up are the main site, the north site, the south site. These represent separate buildings, if you will. You can envision this as an organization that has multiple sites. And you want to have the site, the program is the behavioral health program, the location, 11 happens to be the main site, 12 is the north site, 999 is basically just a general category where the cost center is assigned to those sites. And then down below, you can see there's some grant money down there that rolls into these sites. So when you're looking at this organization's total income statement, total performance, financial performance, all of these would roll up to the top of the pyramid to say total of the behavioral health center. And then when you wanted to see, well, okay, the behavioral health center looks okay in total, I think it should look better. You can drill down and look at what site are you looking at. And then if you look back, we said a few minutes ago with a detailed chart of accounts, if you want to go to the Main Street site, there'd be a whole chart of accounts for Main Street that you go look at and say, well, where is that we were over or underperforming. So having that detail allows you to get to this level of reporting and then drilling down. Next slide, please, Chloe. And so the next part of priorities is the electronic health record and practice management module. There's different ways to look at this. Most electronic health records have the practice management built inside it. The difference between the two, just for clarification purposes, is the electronic health records where all of the employee health information stays, their medical outcomes, their health outcomes, their population management outcomes, who their PCP is, and all those kinds of things that are important on the health record side. The practice management side is the business side. This is where once the encounters are done, they're sent over to your client's accounts receivable group, and they're processing the claims, and they're doing the collections, and they're resolving denials, and they're posting the cash and generating revenue entry. So the practice management side is the business side, if you want to call it the finance accounting side. Electronic health record side is the medical side, where the patients are being taken care of, the clients are being dealt with. This is the same thing. It's important to have this EHR set up to capture the data the same way your chart of accounts is set up. These systems, EHR is going to feed visit data. It's going to feed some other quality data that you might need to turn into financial numbers. The practice management system is going to give you all your revenue and all your payments, your days in AR and all the financial stuff. So all of this has to match your chart of accounts on a one-to-one basis. Everything comes over the way you want it to come over. Within most EHRs and practice management systems, there are miscellaneous fields. And like the system I recently worked with, there was like 15 of them. And this is where we use them to capture things we wanted to know that maybe just a little bit outside of the mainstream. Like if you got denied payment and you get the information from the payer and they're telling you we didn't pay you for this reason, we set those reasons up in the EHR. So at the end of the month, we could pull a report of all denials by reason and then look at those denials and say, there's about 10 or 15 major reasons for denials. There's probably 5 or 6 that you can control. You know, making sure that you're seeing your clients, making sure your clients have insurance, making sure that you bill for that claim within the specified time, either 60 days or 90 days, depending upon the payer. So some of the denials you can do something about, and you want to have a report that tells you that. You want to know about the rest of them because you want to use that in your negotiation with payers. So why don't you pay for this? This doesn't make any sense to us. You know, this is something we think you should pay for. It's an important part of behavioral health. So let's talk about that in the next contract. So that's just one way to use the fields. We use it for a multitude of things, but it gives you the opportunity to pull information out of the EHR and out of the practice management system for specific transactions that you can then use for your operation. Another one that's popped into my mind was we used to track the registration group, people at the front desk were checking patients in. We used to track 7 or 8 key indicators to tell how well they were doing the job, because that would drive denials. And so the combination of those two allowed us to retrain people at the front end, allowed us to react to denials, and that then ties back into increasing revenue. So using that information, developing reports to do that analysis is important. Not necessarily in terms of, you know, tracking cost, but a lot of the outcome of this can reduce cost on the other side. Next slide, please, Chloe. You know, this slide is in here just to give you an example of the practice management system, the EHR system. If we used to look at this a lot to tell us how we were doing in terms of by payer, financial class, what were our charges, what were the contractual allowances. So our gross charge was an office charge that we developed, and then the contractual allowance was a difference between what the contract said they were going to pay us for a client visit versus what our office charge was. And then what we expected to get paid, what do we actually get paid, what was our total denials, what's our net AR. This was a nice snapshot to tell us how we were doing in terms of collection rate and in terms of denial rates and what our net AR is. So this is just one example of the kind of report that you can pull out. You can see that it's listed by the payers that we talked about in the chart of accounts a while back. Next slide, Lloyd. And I mentioned this briefly earlier, but I think a key player in this whole thing in tracking the cost is your human resource and payroll system. And once again, most systems, you know, I've worked with ADP, I've worked at AltiPro, I've worked with Ceridian, they all have a human resource front end of the system, and then they have the payroll system. And similar to EHR and practice management, human resource system starts when somebody applies for a job, they do it online, and then they come in and they get interviewed, and we set them up in the system, we assign them an employee number and department number, all of this stuff goes into the human resource side, and then it transfers over to the payroll system side. The payroll system side has to be able to capture hours. You have to know how many hours a person worked, you have to know where they worked them. I'm breaking up with the type of hours. Was it regular time? Was it overtime? Was it sick time? Was it vacation time? Because those different types of hours are used in different ways and calculations on cost per client and cost per visit and things like that. Also, you want to know how many people work for you. What's your head count? How many people work in your organization? How many FTEs is that? And that's important for a lot of reasons. One is just so you control your cost, and two, there are a lot of governmental reports that ask you to tell you both. What's your head count, what's your FTE, and how is that those two correlate? So the payroll system has to be able to track all of these things. And again, when you're in there setting it up, everything in the payroll system has to map over to the chart of accounts that you've already set it up. So that's why I said in the beginning, the chart of accounts is critical. That kind of drives all of this. And all of these systems have to feed into the way you set that up. Payroll reports. Okay,
oh, I'm just going to add, sorry, Bob, I interrupted, but just wanted to add that in the future, we're going to be looking at activity-based costing, which is driven by exactly what Bob's talking about here. The more detail that you can capture in your systems as far as these hours and the types of hours and the additional benefits and all the real costs of allocating people to a particular team or to a particular program, if you can capture those, you're going to be able to drill down farther into your costs and really be able to figure out what the cost of a particular program or service is. So that's this is a really important part of this, cost analysis system.
Yeah, I mean, when you, as I've said a couple of times, I mean, the personnel costs, you know, your total personnel cost in most health care and behavioral health organizations, you're talking anywhere between 78 and 85%. The health centers use around 80%. I've seen behavioral health as high as 85. But this is the main driver. And I think knowing the head count, knowing your FTEs, knowing the types of hours that they work are critical, because when you're then going to go do your analysis, there are some hours that you include, some hours you exclude, if you want to get real good detailed reports. So next slide, Chloe. So the types of hours, you know, pretty straightforward. Regular hours, you know, if I'm a 40-hour-a-week employee and I work 8 to 5 with an hour for lunch, those are my regular hours. If I'm an hourly employee and I work till 7 o'clock, I'm going to get 2 hours of overtime. Vacation time is self-explanatory. It's days of time or sick time and personal hours. Those are kind of categories of personal time that, and a lot of companies lump those all together now into one bucket. But I think you'll find the most behavioral health and healthcare industries, healthcare places that I've seen, that they still break it out this way. Because some of them, if an employee terminates, some of them you have to pay them, others you don't. So there's a reason why they're tracked out that way. But when you're looking at tracking what's it costing you on a per client basis, you know, knowing the hours spent actually serving the clients is where you want to get this information. So regular and overtime, those are actually worked hours that you want. You don't want vacation hours when you're tracking that, because that could skew it, because they're not really hours worth seeing your client at that point in time. Same with sick and personal. So being able to track that is pretty important. Next slide, Chloe. And this is probably a good example of how you can use all of this, the hours and the payroll stuff. We call it a statistical dashboard, and essentially the top box tells you what your employee count is. It tells you what your FTEs were. It says your total visits. This organization had a pharmacy that was their pharmacy. It wasn't an outsourced pharmacy, so they had, you know, 575,000 prescriptions, and the total revenue 65 million. Down below is taking each part of the organization. This organization had an accountable care organization, had employees working for it that were on their payroll. Central admin, which is all the senior executives and that group. Clinical administration, CSS, development, finance, you know, and the overhead accounts. This tells you how many employees you had and what percent of that was to the total head count, the FTEs you had, what percent that was. And the right-hand side tells you all the costs. Here's your total compensation. Here's your total other expenses. So if you look as an example, the ACO for this organization represented 6.1% of the total cost of running the organization. This is the kind of report that you can pull out of payroll, and then the other expenses and total compensation you pull out of your general ledger, because it all pass in that way. This became a very important report in terms of how this organization looked at their business when they went on a monthly meeting with the senior executives. This became a very important report. It also was an important report in talking to some payers and to some grantors, because they want to see where you're spending your money. If you had a central admin that was up around 10, 12, 15%, that might not be something that a grant organization would want to see. They want to see the money going to where it reaches patients and clients and your people. So this became actually a good tool that we use in some of our negotiations as well. Next slide, Chloe. So talking about income statements, there's two different ways to look at the income statement. One of them is what I call a summary, and it's kind of it rolls a bunch of things together. So if you look at the top section, it's telling you client visits, and it's telling the month and year, the month number, the month budget, and the year-to-date variance. Pharmacy prescription, the same way. So those are the statistical numbers. Then if you look at client service revenue, grant to contract revenue, pharmacy revenue, you come down to your total revenue. And if you just take a simple calculation of all that revenue divided by the visits above, that gives you kind of a global measure of revenue per visit. And I say global, it's very high level, because normally you wouldn't include grants and stuff in a real revenue per visit calculation, which we'll do later, but this is kind of more global. Next slide, Chloe. Then when you move down into the expense side, you see the salaries, fringe, supplies, subcontracts. These are, there's about 15 lines there that all roll together telling you how you're doing actual versus budget. So take any one of those, for example, and you look at facility operations and maintenance, you can see that that's over budget by $54,000. You really can't figure much out by looking at this. But if you go to the next slide, Chloe. And I would even jump another slide, one more slide, please. Okay. Now, when you get into this level of detail, personnel expenses are now broken up by salaries, overtime, and fringe. Supplies are broken up by minor equipment, office supplies, client supplies. You can now see the detail to what was on that first report I showed you, the summary report. And of course, there's no facilities on here, but the way you would work with this is that first report is a summary level. We gave that to our board of directors. We gave that to our finance committee. That's the income statement we gave to outside people who are looking how we're doing for grants. This detail statement is one that the finance staff used to explain what the variances were on the first one. So you need to have this level, and this is why your chart of accounts is set to this level, so you can actually drill down and explain why any individual line has a variance, whether it's positive, whether it's negative. And some variances, if you're way over budget on salaries, well, there might be a reason for that. It could be that you hired people you didn't expect to hire, but also you might have had revenue on the other side to that it made sense to do that. So you need to have this level of detail here and level of detail on the revenue side to really tell you what's driving your organization, what numbers are driving your organization. Next slide, Kelly. One of the other key things, and one of the other key concepts I'd like you to take away from this, and we're going to talk about allocations now, but most CFOs and most finance people loathe allocations in the sense that we want to get as much direct expense and direct revenue charged to the organization and to the site, to the program, or to the department as you possibly can. So you want to get salaries directly to that site. You want to get expenses and your supplies directly to that site. The things you want to allocate are things that I would, for lack of a better term, call them shared services. So for example, not every department, program, or site is going to have social services or enabling costs. Not everyone is going to have client records. I mean, there's usually a central place for that where all of the client records are kept. And if people want to look at that and get copies of records and things like that, they're central. Site administration, client billing, not every department or every site has their own billing people. It's usually a central billing office. So these are the shared services of the organization, and you want to allocate them fairly in a manner that's representative of what drives the cost of those categories, and allocate it fairly to the operating site. So for example, the first group of those, everything says is visits by site. What I mean by that is if you take client billing, we take the number of visits that a specific department or a specific site did and say what percent of those visits represents to the total, and then we allocate the client billing percentage to that site, because client billing is visit driven. You're billing visits and you're doing denials all related to visits. So if site, the Main Street site from our earlier slide, if they did 10% of the visits this month, they would get 10% of the client billing costs for this month. The call center, if they had 10% of the visits, they get 10% of the call center, because the call center is also working on a per visit for a client basis. So those things are all variable to visits, and those are the ones I like the most, because those are the ones you can explain more easily to people when you say, look, we had 100,000 visits, you did 10,000 of them, so you represent 10% of the visits, you're going to get 10% of those costs that are variable to visits. And that's pretty understandable, generally speaking. It's not the typical, I can say this because I'm an accountant, but there are some accounting mumbo jumbo things, but this is pretty straightforward, and I like these. The next one, if you look at facility overhead, again, there are departments, multiple departments within a site. So you want to make sure you're allocating fairly, what you want to call, rent expenses and utility expenses and things that are variable to the square footage. So we would do a square footage assessment every year, would update our floor plans and say that the same thing applies though. How many square feet does the residency department take of this medical site? How many square feet does, and pick something, anything you want to use in your site, occupy, and then take that percentage and apply that to the rent and to the utilities and to the indirect cleaning costs that you have, things you can't charge right to the site. Again, that comes out to a pretty reasonable and easily explainable way to do it, as long as you're committed to updating the square footage every year. I've heard some horror stories where people would do this and then they wouldn't update it for 10 years and the site would expand tenfold and only be paying one half what they should be paying and someone else is paying more. So these are things that you want to make sure that you stay on top of, and if there's any changes, make them, because I have spent more time trying to talk to people in the organization about allocations than about anything else, because this is kind of a gray area to a lot of people. So you want to make sure that you really get the strategy down and you have the numbers to back it up. And central admin is done by percentage of expenses. So to go back to Main Street site, if they're representing 10% of the volume and their expenses represent 12% of the total company expenses, they'll be allocated 12% for central admin. So it's all formula driven, and they're all numbers they're ranking numbers. You can show these to people, you can prove them to people. If you have the detail P&L that I showed you earlier, the income statement, and you're looking at a detail level, people can understand the pluses and minuses that all drive into this. So I would still say you want to get as much direct cost as you can charged directly to a department or a program or a site. And then the things that are shared services that you can't do that, you want to have a method like this. This method also is driven by FASB and GAAP rules. If you're an accrued accounting system, which most people are, this is the preferred method. There's another method for cash accounting, which relies on how much cash you actually collected, and it changes the equation a little bit. But this is the preferred method, and this is a method that our auditors have signed off on. So it's pretty standard, and I think you want to make sure that you have something along these lines. Next slide, Chloe. And so the next series of slides are going to be a couple of things that when you are looking at why you want to capture your cost and why you want to get it to the level that we're telling you need to get it at. If you look at a cost per visit summary, and we can also look at it on a cost per client basis. You just change what you're dividing it by. But in this particular case, we're saying that this organization had total client visits of 84,000. And because we knew how many clients they had per client, they had 13,000 clients. The direct provider cost was $46. The support staff cost was $49 per visit. And you can see it all comes to a total of $161 per visit. Next slide, Chloe. Those numbers come from this detail. So this is why, again, you're into the getting the detail level. So you get the visits, the direct provider cost. This is the salary of the provider, the behavioral health specialist in the room providing the patient care. It's the salary and fringe benefits of that individual, of those individuals. And that then is just divided by the number of visits, and that tells you that for every visit with a client, it's costing $46 and that direct cost. The support staff costs are everybody else that's involved in that client visit. So it would be if you had a behavioral health nurse, if you had a psychologist, if you had a behavioral health medical assistant, somebody that's going to come in and help that patient during that visit. You capture all their salary and fringe. You'd also capture all of the expenses. So if you go back to the income statement we talked about a few minutes ago, every site and department would have an income statement look like that. And then you would take those total costs and put them into this direct expenses, so that now you're capturing all of the costs associated with seeing those clients during this fiscal period. Call center allocation, referrals allocation, again, these are shared services that are serving this site, and they're carrying over from the allocation detail. So if you look at the direct support staff cost, you get direct support staff costs of $49 with all those different places. Next slide, Chloe. This next slide talks about enabling costs, administrative costs, overhead costs. Enabling costs is a kind of a broad category. You might call it something different, but it's meant to capture those things that I would say things like transportation, helping one of your clients get from home to you, helping one of your clients get from you to a specialist, from you to a pharmacy if you didn't have a pharmacy. That'd be kind of an enabling kind of cost. You're enabling the client to get the care they need. And there's many others, but that's kind of a good example, I think. So you would have how many people are involved in doing that, and we do have some salaries involved in that. The enabling expenses would be the cost of the transportation, the taxi, and everything else, food vouchers and things like that you're giving your clients to help them cope. So that comes out to $1.50 a visit. Administrative costs, pretty straightforward, central admin, billing, and these are write-off income statements and detailed income statements, so that's $42. Site overhead would be for that particular site, that particular building. What are the overhead costs there that are not part of central admin? And then you look at your total cost. So you take all of these component pieces, and that's where you get the $161. Now, when you compare that $161, there are benchmarks you can look at. Dave and I looked, and we struggled, I think, to find a lot of behavioral health ones, but there are a lot of benchmarks. If you look at MGMA and some other medical groups, where you can look at what those should look like. And in the health center world, there's a big advantage in the sense that the National Association of Community Health Centers and some of the cost reports that are done that behavioral health doesn't have actually helps give you benchmarks for this. But this is one of the examples of the kind of detail that having your general ledger and everything set up the way you need it to be set up, you can get this information. So next slide, Chloe. So one of the things that I think is important to do is on every one of these slides, we talked about getting reports for analysis and being able to look at the numbers. We looked at this and kind of saying, okay, if you're a CFO, what are the things that you want to get reports on, you want to look at daily, weekly, monthly? And some reports are more important than others. So I'm suggesting here that for the CFO, and this is my experience and other CFOs I've worked with, cash activity is critical. So what's your daily cash balance? What were your receipts today? What did you disperse today? What's your cash on hand? How many days in cash on hand do you have? A critical measure. So CFOs look at that every day. Now, third-party collections, I was in the habit of looking at that, but not everybody does. I just like to know what came in yesterday, and how we do on collections. Are we collecting 80% of what we build, 90% of what we build? And if we're not where we should be, what are we doing about it? Again, and looking at your biggest expense is the whole payroll and compensation side. So looking at new employee list, how many new employees did we bring in this week? And that report should tell you, are they new employees in the sense that they're filling a vacancy, or are they brand new employees where you didn't have a vacancy or a total add to cost? So looking at that report and knowing that is very important to understanding your salary cost. Terminated employee listing kind of goes with that. So what's the delta between those two? How many people you bring in, how many people left? And I used to like that report to tell you how many people self-terminated, how many people were terminated, because what that tells you a story about what's happening in your organization as well. Scheduled vendor payments, I looked at that on a weekly basis. That just basically said, here's from accounts payable, here's what we're going to pay this week. And you flip through that and you look. I used to look at any large checks to see why we're paying someone that much money. Yeah, that makes sense, doesn't make sense. But that was a report that if I didn't look at it every week, I had other people that did, which was fine. The next group, business by site and program every week, total head count every week, and the total clinical hours worked every week. We had a report that was developed that went to not just me as a CFO, but it went to every employee in the organization to say how did the organization do this week in these key categories, because these were the key categories that measured the success or lack thereof of the organization. Next slide, Chloe. The detailed income statements that I showed you a few slides back, those are done monthly, and there was a lot of analysis done on those, and I see if folks, you spend a lot of time looking at those. That tells you the story of what's happening. Third-party age receivables, again, if salaries are the most important expense line and personnel costs, then your third-party AR and your collections are the biggest part on the revenue side. That's where the majority of revenue comes from. Looking at that aging, knowing what payers owe you and knowing how old your receivables are, again, tells a story about your billing process, tells a story about your collection process. So we used to do a lot of analysis on that. Looking at denials and collections kind of went hand in hand with looking at the aging analysis, because those were some of the reasons why aging would look the way it looked. A statistical summary report, I showed that to you a little while ago. That's the one that broke out the organization by the major sections and showed you the head count and FTEs and the cost of each one of those sections. The cost per visit, cost per client report we just walked through. It's another thing that I think that the CFO needs to spend a lot of time on. And those two numbers, when we talk about negotiations with your payers, particularly, those are numbers you need to have, because if you're on a fee for service per visit basis, you want to be able to tell them, here's what it costs us per visit, here's how we get the number. If you're on an ACO or a PMPM, the cost per client is the big number, but you got to be able to show them both. Just a little story there. I had a personal experience with tracking these numbers where we were sitting and talking to the state of Massachusetts about a whole negotiation on cost and getting reimbursed. And the director of Health and Human Services said, well, you're telling me you need more money, but none of you guys can ever show me your expenses, show me what it costs you in your organization. And we pulled out these reports and showed her, and then with Judy and Bigby, for those of you who might know her, she was like, wow, this is incredible. How come no one else does this? And I said, well, I think a lot of people do it. They just don't maybe do it to this level. But that made me a believer that this was the right thing we should be doing. And I think that another quick story, Dave and I had a conversation with a payer as part of putting all our research together for our series. And I asked the question, Dave, you remember this, I asked the question, how many times have you had a provider come into you and say they want to negotiate a better rate and lay out for you this level of detail of costs, where their costs are? And the answer we got from that payer was never. So to Dave's point earlier, you want to be on offense. You want to be driving how the game is going to be played. So you got to go in there and say, these are my costs. This is how I capture my cost. And this is why you need to change your payment rate. So all of this leads up, I think, to getting that. Next slide, Chloe.
And I just want everyone to know we just have a couple more slides left, but if you do have a question, feel free to answer or ask it through the chat box located on your GoToWebinar toolbar, so we can get to those as well before, after the presentation concludes.
Okay. Next slide. So this next slide is just if you have a lot of grants, some health organizations have those, behavioral health and other medical centers have them, making sure you know who your grants are from, how much the grants are for, what the rules are doing the proper billing, and you write down. I used to do every month to make sure that we were billing properly and making sure that you didn't get to the last 2 months of the year and had 50% of the grant to spend because we weren't doing grant spending during the year properly. So that was kind of a good way to control that. Next slide.
Well, Bob, let me, if I can add in here a little bit, these overarching reports that you're talking about here are really incredibly valuable. And to bring it back to the beginning of the presentation, you can do these reports if you set your systems up correctly. You can bring these reports down to the site and the program level, because as you know, if you've got certain teams or providers who are working in a particular location or on a particular program, they're interested in the health of the organization and the overall, but what they want to know is how are they doing versus others who are doing something similar perhaps in your organization. Or if your third-party receivables are, your aging showing that you're not collecting, how much of that is due to my shop and how much is due to the next shop? So it's a little bit of an internal competition thing that goes on, but when you have the data driven by program, driven by site, you can answer those issues, and you'll find that will catch people's attention.
For those, if you remember back early when we were looking at the chart of accounts, there were chart of accounts broken out that had this a grant receivable and had a title of a grant. This grant and contract summary award, there's an account for each grant. So you can look at it and say, here's my balance of grants. And then what grant is it? And what grants do I have the balances on? And what grants do I need to go out and do some reconciliation of? So you got to be able to drill down to that level. Yeah. I've seen some situations where an organization has just one line called grant revenue. And then you say, okay, so where does it come from? Well, we go in and run a bunch of reports and we dig back and find out. And I said, well, how long does that take? Well, it can take maybe a day or two. Well, then why don't we just set up a cost center and track it so you know instantaneously? It's probably less work to do it that way than try to go back and dig out later. So if you look at the next group, the Director of Finance report, some of these are similar. You know, the Director of Finance wants to make sure that everything that gets into the journal ledger is correct. So you want to look at all the journal entries, you want to look at all the cash disbursements reports. You want to make sure that your AP edits are right, your payroll edits are right. Everything is going into general ledger. This is the person that has to look at them and make sure they all make sense. On a Director of Client Accounts, you know, this is all the billing, making sure that we're doing the billing every day. If you have most places have a clearinghouse where you're transmitting the data, you want to make sure you transmit it, you want to make sure they transmit it to the payers. So you got to have reports to track that. The collections we've talked about a few times, but this is the person that's going to be doing it at the detail level. And I will add, if you don't have a Director of Finance, you don't have a Director of Client Accounts, the people who are the lead people in each one of these areas are the ones that should be doing it. So these are just titles that we're familiar with, but it doesn't have to be these people. It just has to be the person most best suited to do it in finance or in the client accounts area. Next slide, Chloe. And we touched on some of this earlier, third-party claims, denials. This person is looking at all that detail that gets us to the reports that we showed you earlier. So we don't have to go through them. We'll kind of talk about those a little bit. Next slide, please, Chloe. And so some of the things that get in the way of all of this, the obstacles to doing these things, and there are many, and over the course of time and working with other health centers, these are the most common things. I can't do these because we don't have the staff at the time. And generally speaking, you know, that can be a very valid thing. You don't have people sitting around waiting for projects to come up. You don't have people sitting around to do all this, what looks like a tremendous amount of work. We don't have the systems. We touched on that earlier. You have to make sure your system does have that capability to do these things. And I would suggest to you, if you're using systems that don't, you should be looking at upgrading or getting new systems, because this is going to be the way of the healthcare world, behavioral health and the rest of the healthcare world, to be able to have this granularity around your cost, to be able to negotiate more effectively. We don't capture cost at a detail level. That's why we're saying you got to go back and look at the chart of accounts. You got to make the commitment to do that. And last but not least, you know, we don't see a real value. Why should you do all this work? What does it get us? I think that I've given you a couple of quick stories, you know, what that gets you, but also it helps you determine. So let's say you're in a downturn and things aren't going well. There are a lot of ways to do things. You can say, well, let's just cut everybody 10% across the board, or let's do this. But if you have things to this level of detail, you can go in and say, well, I can see that this particular unit is not performing well. So maybe if I'm going to make a reduction, I'm going to make it there. I'm going to reinvest that money into this place that's doing much better. Hard decisions, but now they're data and number-driven decisions. So I think that's the value. You got to make people understand that that's the value. So those are, I think, some of the bigger obstacles that we've heard more often. Next slide, Chloe. And so some of the approaches to overcoming them, I would say, generally speaking, the heavy lifting here is setting all this up the first time. Once you set up the chart of accounts, you get the general ledger set up, and you set up your payroll system, now it's just transaction processing, putting things into the proper accounts in the proper places. But it's a lot of work to set it up, and I'll grant you that. So some of the ways to overcome it, outsource some of the work to your vendor partners. For example, when I've gone through general ledger conversions where I brought the general ledger company in that we were converting to, they sent their conversion experts in to help us bring the chart of accounts over, to help us write the reports that we wanted in the report writer. So we would pay for that resource as a one-time setup. Using other consultants, other consultants. I mean, in one of our environments, we had a consultant come in. to help us look at coding, how to train people on coding, how to improve our coding and our risk score. So you bring them in at that key point. They're not there forever, they're on a contract basis, and if they come in and they go out. If you have people that are going to do the work, I would strongly suggest you have to provide protected time for the team to do it. You can't say you're responsible to make this happen, and that we know it's going to take 2 months to happen, and then be constantly pulling the people away from the project time, the team time. So you got to give provided protected time for the people doing the work. Along with that, you have to have a realistic plan. If you're going to convert a general ledger system, you cannot say we're going to go from system A to system B. We're going to do it in 7 days. Not going to happen. So you got to have a realistic plan, and usually your vendor partner will help you lay that plan out. So you lay the plan out, you give the protected time, then you stick to the plan. When I say stick to the plan, you can't let things slide. Well, today was a deadline for this. We'll wait till next week. No, you got to get it this week. So you got to be on top of that and stick to the plan. And then to help pay for some of the stuff, there are grants out there that will help you, that you can get to improve infrastructure, to purchase equipment, to purchase software. And I've used them in a couple of places. So those are some things you can do to help overcome the obstacles. Next slide, Chloe. So I think some of the things to consider that we've talked about, we're talking about doing things at a very detailed level. We're talking about trying to capture costs at a very granular level and making sure we can put everything in its right place at the right time. At the same time, you got to find the appropriate balance between what we call between perfect and good. So if you can do your work, you can get your reports, you can get your systems to get you into a 97 or 98% accuracy level. Well, if you want to go the extra mile, try to get to 100%. You might miss having good enough information to make better decisions. While you're chasing that 2%, you could be throwing money out the back door because what you had was good enough. So you want to develop the system with that balance. You know, don't let striving for perfection get in the way of achieving really good. And then things to consider: what reports and tools and metrics will you need? I've walked you through a few of them. There are many more, but defining for yourself, what are the things you want to know about your organization, about your financial numbers to tell you how you're doing. Cost per visit, cost per client. Some places measure what it cost you to generate a payroll check all the way from beginning to end. Some places measure how many hours, how many invoices an accounts payable person can do per hour, because that drives your metric and drives your payroll cost for that. So developing what reports and metrics do you need, and then make sure you get that information. I think the next two are critical, very critical. How are you going to teach your people the value of all of this and how to use the reports and metrics? You can do all of this work and you can get it all out there and you can have done a almost perfect system. And then if you send those reports out and you haven't told anybody in your organization how to use them, the value of them, and what the metrics tell them, you really haven't accomplished anything. Specific training. How are you going to teach the people in the organization how to use all of that? So I think of the two things that I've seen where this just falls down, it's not making sure everyone understands the value and how to use them, and how our finance and client accounts people will be trained to make all this happen. Okay, so that is the walkthrough. Hopefully you find it helpful. I don't know if there's any questions on Chloe. I can't see that, but
we've come to the end of the session, and we sure appreciate all your sticking around. The last slide here kind of gives you a sense of what we're going to talk about on the next presentation. We're going to get much more detail on value-based payment systems, not necessarily going through and listing all of them and their attributes, but kind of walking through how your world changes when you need to be demonstrating outcomes and getting paid based on those outcomes. Because as we know, it's a little more difficult in the behavioral health world sometimes to demonstrate when someone has achieved a milestone or has reached a benchmark of stability or community engagement, and a lot of the social determinants of health factor in. How does that work with your payment? How do you convert that data into augmenting your revenue stream because you are participating in that person's reintegration or stability within the community. Difficult choices and challenges that you face every day. We'll talk about developing the care pathways that you can use to not only provide, and this is not a programmatic session, it's a costing session, but once you set up those systems, you can walk through how you would cost them and therefore be able to justify higher payments for making the additional interventions with your clients. And then finally, we'll be doing that through discussion of some of this time-based, activity-based costing. So that's going to be coming up. We for sure appreciate and hope you guys will join us for that. And the last slide is all our contact information. If you have questions you want specifically answered, don't hesitate to contact Bob or I. And we hope to see you at a future show.
Thank you, everybody. Thanks for coming.
I want to honor everyone's time. I know we came, we're a little past the hour here, but I still want to just keep, since we have you on the line, Bob and Dave, if anyone does have any questions, I'll keep it open for just a couple minutes to see if anyone has any questions they want to ask for this presentation. Of course, if you do think of anything after, please don't hesitate to reach out to any of these contacts. You can see Dave and Bob's email on here, but just wanted to keep the questions open on the chat box located on the GoToWebinar toolbar on the right-hand side. If anyone has questions, like I said, I'll just keep it open for another minute or so if anyone has any last-minute questions. The slides are available in the handout section too. On the right-hand side, you'll see a little drop down that says handouts, and the slides are there. But you also will be able to find it on our Capital Link website, on the Delta Center website as well. You can see the recording and the slides. I know some people had a couple questions on that. All right, it doesn't look like anything else is coming in. Bob and Dave, thank you so much again. And after you close out the session, you will be directed to a very brief survey and appreciate any feedback you're able to provide.